The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back, Sky community. Welcome to another episode of Sky Women's Health Podcast. Today, we are talking about the Pap smear, the HPV testing, what is going on with at-home HPV testing. And we have an expert here with us, Dr. Richard Hopley, who is a pathologist with PathAdvantage, an associate medical director, and someone who I lean on a lot. One of my favorite labs to work with, PathAdvantage. I've been working with them for the last 5 years, and Dr. Hopley is never scared to pick up the phone and talk to me through certain case scenarios or to even call patients when they have questions. And it's rare that you find a pathologist who really is so into women's health and really engaged in the patient experience. So I really appreciate that, Dr. Hopley. I just am so grateful for our working relationship.
Thank you. Thank you very much. Thanks for having me. And thank you, too, for being so accessible. Pathologists, especially the ones at PathAdvantage, are not there is a stereotype of a pathologist being, somebody who works in the basement, which traditionally was where pathology was located. And we're all scared of talking to not only patients, but other doctors. But yeah, especially here at PathAdvantage, we're very open. We love reaching out to our docs, and we love it when they reciprocate, like yourself.
Yeah.
I love what I do, and I love talking to our clinician colleagues.
Yeah, well, it shows, and we appreciate it. I mean, I had a patient that I saw for a colpo just 2 days ago, and so she had an abnormal pap smear. We did a colposcopy, and we scheduled her for her follow-up to discuss the results next week. Well, she was floored when we called her this morning and said, "We have the results. Could we get you on for a telehealth?" I mean, that's great customer service. Just the turnaround that we get is pretty remarkable.
That's right. That was one of Dr. Alexandra Gillespie's primary tenets. Dr. Gillespie is our founder of PathAdvantage and our primary medical director. And she always operated with this idea of a 24-hour turnaround time for essentially everything, even biopsies, which is almost unheard of. And she loves to present that so you can get the result while that patient is still fresh in your mind and you remember the experience and what you saw during the exam. So having that result so quickly instead of 2 weeks later can be invaluable, I think.
Yeah, absolutely. Because, many times I call you and I go, "Are we sure about this? Because this is what I'm seeing clinically." Maybe I didn't represent that well in the pathology before, or in the requisition. Well, let's get into talking about the FDA recently approved an at-home HPV testing. It's being marketed as this screening revolution. But you and I both have a little bit of reservation and concerns about this. And that's why, in the medical community, I think you have that range of enthusiasm and concern, right? Because we really want to understand what, as clinicians and patients, what does the shift really mean? And you and I were chatting that, a lot of times patients assume they had a pap smear if they had a pelvic exam, but they are not equivalent. So a pap smear is a particular swab of cells that is collected at the time of a pelvic exam. But at-home HPV testing is different. Tell us more about that.
It certainly is, and I'd love to. So the pap smear has come a long way since Georgios Papanikolaou discovered it in the 1940s. And I was actually just reading about that. It was surprising to me that it really only became really widespread in the 60s and 70s, which to me, I thought it was a lot more prevalent, much earlier than that. But the pap smear really was revolutionary, and I would say probably one of the most successful cancer screening programs ever launched. and it has continued to be so today. I mean, cervical cancer was maybe number 2 or 3 killer of women,
Yeah.
and now it's gone down to 13, 14, or something like that. And rarely do you hear about it, whereas in the 50s, 60s, it was very, very common. The pap smears changed a lot. And I think in the 90s, they discovered that cervical cancer was essentially caused by a virus, HPV, human papillomavirus. And then we learned that we could test for the virus as well as looking at the cells, which is what essentially a pap smear is. So there's 2 arms to this, a pathologist and a cytotechnologist, which is like an assistant to a pathologist. Will look at the slide and actually look at the cells. And then in some cases, or you can also do a test for HPV, the virus that causes cervical cancer. Lately in the news, I've very exciting news about the pap smear is about to be replaced with this at-home HPV test. And there's a lot of excitement about that because it makes it sound like I saw one article, it said, the days of a cold metal speculum in a cold, dark doctor's office are over. Now you can have this convenient test at home. And I'm not opposed to additional choices for women. And I think it's actually wonderful that there are more choices because that can only lead to more screening. But I think it's really important that we're informed about those choices and what the difference is between a pap test and the HPV test.
Mm-hmm.
Let me explain a little. So because HPV is essentially the cause of the vast majority, I mean, for the sake of this discussion, let's say all cervical cancer, it stands to reason that testing for HPV should really solve your problem. But it's not that simple, unfortunately. A lot of cancers, maybe about 5 to 10% of cancers, are negative for HPV. So if you're putting all your eggs in one basket, in this HPV testing basket, you're going to miss so many cancers. For some women, the risk of the chances of them having cervical cancer may be very low. So maybe that's not that big of a deal, this decreased sensitivity. But for the population, it's. I mean, did you know, for example, that up to 10 or more % of cancers could be negative for HPV?
Mm.
I don't think that's that universally known.
Yeah.
I think it also assumes that cytology, or looking at a pap smear, doesn't really contribute anything. I mean, the pap smear actually tells us a lot about a woman, not just whether or not she has cervical cancer. We pick up on any infectious organisms. We pick up on the hormonal status of a woman from a pap smear. We look at endometrial cells, and we find not just cervical cancer, but we pick up on endometrial cancers. We can tell you if the smear, we tend to call it a pap test, actually, these days, because it's no longer prepared by a smear as it was in the old days. We can tell you if that was adequate. If a woman didn't collect a good sample, then, and your test was negative, we don't know, was it negative because the virus isn't there, or unfortunately the patient didn't collect a great sample?
So I think that it's interesting in that, yes, there's this perceived convenience. Perhaps we would get greater testing from individuals who may fear coming to the doctor's office or
Mm-hmm.
may fear a pelvic exam, right? History of
Right.
assault or things of like that nature. Especially in rural communities or where transportation or childcare barriers could contribute to them not getting screening, right? So I think from that perspective, it's could be valuable, but I agree there's so much that can be determined from a pelvic exam and from looking at the cervix and from collecting those cells. And yes, how many times have y'all told me that there was trichomonas present or there was a shift in bacteria or, something else is going on there. So I think that it's incredibly invaluable for patients to understand that just because you've had a pelvic exam or somebody's looked with a speculum at your cervix doesn't mean that that swab of cells was collected, especially is not collected in the ER. That screening exam is never done in the ER. Um, let's talk about when we need to screen. What are the screening guidelines? When do we start screening? When do we discontinue screening? I think that can get a little confusing for people because, as you mentioned, it's been a home run in terms of prevention of cervical cancer, detecting it early and treating. But a lot of people still remember that annual PAP, and it makes them very
Mm-hmm.
uncomfortable that you're going to do screening every 3 to 5 years.
Yes. The the older guidelines of screening every year predated this HPV testing. And back then, a clinician such as yourself would do a brushing of the cervix and literally smear that brush onto the slide. That slide, quite frankly, that's called a conventional smear now. That slide is not very fun to look at. It's very difficult. It can be a lot of what we call artifacts. The cells can dry. The cells clump up on top of each other. There can be a lot of mucus there. And all of those things worked together to make it not a very sensitive test. Cancer can hide quite well under those clumps of cells. So because that kind of test was not very sensitive, it was best to do it every year. One of the good things about cervical cancer, and I say good in quotation marks, of course, is that it tends to grow very, very slowly. So if you didn't catch it that first year, then maybe you caught it the next year. As testing has improved, we now use what's called liquid-based cytology, and we prepare those PAP tests now with machines, which makes it a lot more standardized. And we get a nice button of cells. They're all in a nice layer and spread out, so we can look at those cells a lot better. So the studies show now that we can actually go a little longer. In practice, I find that most of our clients go 2 to 3 years. They don't like to let it go longer than that. It can be a little scary. I mean, you have thousands of cells on this PAP test, and only 1 or 2 of them sometimes show cancerous or precancerous features. So our clients know this, such as yourself, and I don't like to have 5 years between visits.
Yeah, so I recommend annual exams regardless, because I always remind people
Yes.
we're more than a pap smear. I mean, when we're doing an exam, we're looking at the vulva, at the skin, at the clitoral hood, at the muscles of the pelvic floor, as well as the cervix, uterus, ovaries, etc. But I agree with pap smear screening, starting at age 21 and 21 to 29 being every 3 years, as long as it's normal. 30 and older, it's pap plus HPV. It can get rather confusing. And if those are both negative, supposedly you can go every 5 years. So it can get rather confusing for people. Did they have HPV? Did they not? Were they with your practice that previous year? So in my practice, as long as we have normal pap smear screening, we're doing it every 3 years for everybody. I'm not extending it to the 5 years. I just think that it gets cumbersome, and I don't want anybody to be missed. So there's recommendations, and then there's your practical, care of the day.
Right. And I agree with you, if I may. I mean, forgive me, I was just describing the pap smear itself. You're absolutely right. I think for women's health, just as I see my internal medicine doctor every year, I think a woman should see her OBGYN for a well woman exam every year. It's not just about cervical cancer screening.
Right.
Like you say, you get a pelvic exam. You can cover all manner of topics in that visit. Just because you didn't have a PAP does not mean you then get to skip your well woman exam. You don't need a PAP for the next 5 years. No, I'll still see you next year, I think is. And now that's a danger, I think, of this HPV testing at home too. It's now the doctor doesn't even get to lay eyes on you. Mm-hmm. So I do think it's important. I mean, I do think it's good for, someone's having a terrible year. And forgive me, I know the irony of a man talking about the difficulties of getting a PAP test. I've never had to suffer the the indignity of having one. I have my own pleasant visits to the physician, but I've never had to do one, of course. But I understand. I could see a very busy summer, a difficulty with childcare, or plenty of reasons to occasionally choose this at-home test, but with the knowledge that one should follow up for that well woman exam or in-person pap test. I think I should add that the American Cancer Society and the organizations that have approved this at-home testing, they've approved it really for a small subset of women. They call it average risk individuals. And how many of us are actually average? A woman must not have any symptoms, no abnormal bleeding, no discharge. She cannot have had any abnormal pap tests in the past. And I don't actually know what that means, because then it gets really complicated. So if you had a positive HPV test in the past or an abnormal pap test result in the past, you're not really a candidate. You're no longer considered average. And so sorting through that, going, well, you were HPV positive 20 years ago. Can you do this? I'm not sure. Whereas we do know that the pap test and the HPV test, that co-testing, is for everybody, no matter what your situation is.
Right. And I'm wondering, does it have to be ordered by a physician? I'm assuming so. And then if they need follow-up, how is that right? I mean, are we missing STI? We're already talking about missing like pelvic exams, but what if, you know, there's ovarian or uterine cancer concerns or symptoms that aren't being addressed because they're not actually seeing the physician?
Absolutely. No, you're totally right. You, those doorknob questions that you can get as you're about to leave the room, and then the patient goes, oh, I've had this, I've had irregular periods. And then it leads you down to a discussion or maybe a question that you ask your patient. And she goes, oh yeah, I have had abnormal discharge, or I've entered menopause, or all kind of things. And none of these are going to be covered with this at-home testing. And as you say, follow up. If you have a positive HPV test, I mean, this does not get you out of going to the doctor. It really just potentially delays your visit to the doctor and puts the onus really on the patient. I mean, you're right. I believe that these do have to be ordered by a doctor, because a doctor is going to see the result, and I believe insurance covers it. But then if the HPV test is positive, then that puts the onus on the patient to then follow up with their doctor and have a repeat pap test. So now you've bought yourself an additional pap test, because as the American Cancer Society says, this at-home HPV testing is acceptable, but acceptable does not mean equivalent. They do say that it's preferred for a doctor to collect the pap test. And the reason is, as you can probably describe better than I, you will visualize, you'll actually see the cervix, and you get to sample the transformation zone of the cervix, which is where cervical cancers arise and where HPV likes to live and do its damage. Whereas, of course, a woman is collecting her own sample is really just getting a vaginal sample. She of course cannot, unless she got really lucky, could not sample the transformation zone of the cervix by herself.
Right. It's a very precise location.
Right.
That sometimes eludes us.
No, I'm sure you hear it all the time. It's very challenging to even visualize sometimes. Yeah.
So I want to get your opinion on discontinuing pap smears at the age of 65 with your current recommendations, because I've heard some pushback recently about this, and that we may miss cervical cancer in our aging population. And I think that there's this assumption that maybe they're not sexually active anymore, but I have plenty of women who are in those postmenopausal years who are getting back out there. Maybe they're widowed and they're telling me it's a rough crowd.
I've heard the same thing. Yeah, you're right. A couple of things. First of all, you can absolutely get a new HPV infection after 65 if you get a new partner. We see that. Goodness, we see chlamydia in patients of that age. A new partner is a new partner. It doesn't. Chlamydia and HPV does not discriminate because you're got a few years under your belt. Yeah, I mean, if you have a woman who's had adequate negative screening and no history of high grade disease, then you probably are okay to discontinue pap tests. But again, how many women have that history? And do you have the records for that woman dating back 30, 40 years? And how many patients actually remember what they have? Some patients, I've known older ladies who actually want that pap test every year because it's part of their it's part of their workup. They feel reassured
Yeah.
by having it. Something that we actually see that sometimes puzzles some of our clients is that despite being monogamous and not having a new partner, or maybe husband passed away and not been sexually, or for whatever other reason has not been sexually active in years, a woman can test positive for HPV again despite being negative for many years. And the reason why we think this is just like shingles, which is a chickenpox virus that comes back as our immune system wanes as we get older. HPV can do the same thing, we think. And so all of a sudden, your mother has a positive HPV test, and very often it's us, the laboratory, that gets the call and question, did you all make a mistake,
Right.
But no, it's HPV can persist. We think it can lay dormant in the body, in the basal cells of the cervix. And as our immune system becomes senescent as we age, it can certainly pop back up again.
Well, that makes sense to me. I mean, we see it in pregnancy all the time where somebody's been
True.
negative and then it comes up in pregnancy as they're immunocompromised. So we know that there's this high rate of transient HPV infections within a couple of years. Patients often clear it, especially in the younger population before 30. Do you feel that at-home testing may increase our false positives and lead to unnecessary colpos, increasing the healthcare burden or anxiety or confusion?
That's a great question. So, first of all, that group of younger women there between 21 and 30 is not considered a good candidate for at-home HPV testing. As you know, you typically don't do HPV testing in that younger population because they're sexually active and are more likely to have different partners, as we're all dating that age and trying to find the one.
Okay.
And so finding a young woman who's positive for HPV is, you need to watch them, of course, but HPV is so much likely to regress in a healthier younger woman with a, healthy immune system.
Yeah.
So primary HPV screening is not recommended in that population. I think my fear of false positive results is much less than the fear of false negative results, which will lead us to miss cervical precancers, which we call dysplasias, or adenocarcinomas. Adenocarcinoma, a cancer of the endocervical glands, is less common than what we consider the conventional squamous cell carcinoma of the cervix, but it's a whole lot more deadly, and it's a lot faster moving, and it's can be a lot more difficult to detect. And it is a little more common in women in their early 30s, but it can absolutely happen in your 20s. And so I'd be very scared. I'm actually very scared about these false negatives, which can happen for all kind of reasons. We think that these tests are infallible. I'm negative for HPV. I don't have the virus that caused cervical cancer. Therefore, I cannot have cervical cancer. And as I started by saying, about 5 to 10% of these cancers can be HPV negative. There's different strains. There's more than 100 strains of HPV.
Right. And we can only test for how many are on the pap test now?
There's about 14 on
Okay.
the cocktail, depending on which cocktail you use. It's plus minus a few. And then with the three big ones, 16 and 18 and sometimes 45. So if you get positive, if you're
70% of cervical cancer, correct?
Absolutely, yes. And it's worth mentioning, I think, that if you do have a positive at-home test and you end up being positive for the type 16, you go straight to colposcopy. You don't even have a interim pap test. So sometimes that's not a very nice thought either. That's your first encounter with your doctor. You did your at-home test because you live in a rural location, and then it's positive for type 16. Your first encounter with your doctor is going to be a colposcopy, a biopsy.
Yeah. So let's
which
explain what that is. A colposcopy is an exam similar to a PAP where you're getting into the stirrups, the speculum is placed, the cervix is visualized, acetic acid or vinegar water is applied to the cervix for a couple of minutes. And then we're looking at the cervix with a microscope, essentially. It's called a colposcope. And we look at that endocervical, that transformation zone that Dr. Hopley was mentioning, that where the cells transition from the cervix squamous cells to the endocervix. And those are the areas that we look at for any vessel changes, any white changes, any thickening, any mass, and we're biopsying those areas. Now, something that is really unique about PathAdvantage and has transformed colposcopies for me, and I cringe anytime I have to get out a Tischler biopsy now, is that we used to take these punch biopsies of the cervix, but PathAdvantage has these great little, well, would you describe those? They almost look like a little Brillo pad that I press against the area of abnormality and turn, and I'm getting the same results with less trauma to the cervix, less pain. I let patients use Pronox if they wanted to relieve their pain during their procedure, regardless, or their anxiety over the procedure. But usually they're not having much pain with this type of soft tissue biopsy we're using.
you're so kind, and I love that you offer Pronox to your patients. I think that should be standard in in all OBGYN offices. And it is very kind of you to offer that. Thank you for your kind words about the soft biopsy. That's we do offer them. We didn't invent them, but we were very strong proponents of them for all the reasons you mentioned. Yes, and they're called the soft cervical biopsy because unlike the Tischler, as you started off saying, which is just essentially a sharp cutting instrument, right? A punch biopsy that literally cuts into the tissue, and the soft biopsy has this. It's called Chylon, and it's almost like Velcro, little tiny hooks. And when I say hooks, I mean, gosh, they're microscopic, and they sort of grab and lift the tissue from the cervix. And it's actually a little more preferential for dysplastic or precancerous tissue. Precancerous tissue is not doing its job. The function of the cervical squamous cell is like a barrier, a mechanical and a barrier against infections, or keeps everything where it should be. But when it becomes cancerous, it doesn't do what it's supposed to. So those soft biopsies lift off almost painlessly.
Mhm.
Um, and yet we still have enough tissue to look at under our microscopes. And we're not burdened with all of that underlying connective tissue that you inadvertently remove when you do a Tischler biopsy. So
Yeah.
yeah, and we love these because not only do we get what we need, but typically the more biopsies you perform of your patient, the better we can understand her biology and the picture of her health, rather than, sometimes I see just one punch biopsy, one big Tischler biopsy, and that's all I got. And I know it's because the poor patient hit the ceiling and then wouldn't let the doctor near her for a second biopsy. So, yeah, we love these. And I'm grateful to you as your patients. I'm sure that you carry these soft biopsy devices.
Yeah, and I tend to biopsy almost the entire cervix. As you know, we're getting a region. And so I think just for patients who are listening and understanding this, when we're screening, it's so cool that we can screen for this cancer early and catch it early, right? But when we just have a swab of cells or we have a HPV typing, the pathologist doesn't actually have the tissue cells. And so the biopsy gets more cells available, right? And so then you can tell us if this is a mild dysplasia or if this is something moderate or severe that we need to be more concerned about. And then we need a LEEP or a cold knife cone. We're actually resecting that transformation zone of the cervix where you have that entire tissue specimen and you can tell us if this is invasive or not. So the whole point is ruling out that invasive cancer before the
Hmm.
whole point is ruling out invasive cancer,
Correct.
catching it
Correct.
early.
Yes, we don't look for dysplasia or precancer um, just to find it. I mean, the whole point, as you say, is a lot of these women will regress. Their immune systems will kick in, will kill the virus, and therefore kill the precancerous cells as well.
Yeah.
Um, but the reason why we're looking for, these low grade dysplasias is because they can turn into high grade dysplasias, which means they then can turn into an invasive cancer. So the whole point is to catch it early, as you beautifully said, before it's too late. Because once it's invaded, the horse has left the barn, if you will, and now you're playing catch up. So it's much better for everybody to catch it early before it's too late.
Agree. Okay, so we've covered a lot. Co-testing, your PAP plus your HPV is going to be your highest sensitivity.
Correct.
PAP with reflex HPV. So if that PAP, that swab of cells, is abnormal, then they'll do the HPV testing. That's a strong alternative. That's what's recommended between the ages of 21 and 29, as you mentioned, because we're more sexually active during that time frame as well, and picking up HPV, which usually clears. Over 30, it's PAP every 3 years or PAP plus HPV every 5 years. Or if you're in my practice, we're doing a PAP and HPV every 3 years.
Bless you. Yes.
I think that, HPV only screening needs to be approached cautiously. And as you mentioned, there's limitations into who could do that. So it sounds like it's the woman over 30 who's never had an abnormal PAP smear and has no abnormal symptoms and da 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 da. And then patient counseling. We have to address the limitations of at-home testing, right?
Right.
Yeah.
And, I don't know how you would do that. I don't know how you can encompass the nuance, all these nuances that we've been talking about now for 40 minutes. I don't know how you can encompass all of that in a little package insert. And maybe they do. I don't want to take anything away or accuse anybody of this, but we're a couple of doctors here, and I find some of these guidelines confusing, and who falls into this average risk category. And as I've said before, we know that co-testing is for everybody. That works for everybody. I think it's good to welcome these new technologies and new tools. But absolutely not to forget the what got us here and what saved so many lives, what actually works. And, I don't want to sound old fashioned, but I really strongly believe if it's not broken, you don't have to fix it. And maybe it was COVID or telehealth, or, you can buy at home cholesterol tests. I mean, my goodness, you can analyze your genetics, your ancestry, and find all kind of things about yourself from the convenience of your own home. And
Sure.
And Lord knows a PAP test is if a woman can avoid it, she doesn't have to go through the whole rigmarole of preparing for it and sorting childcare, taking the day off for work, and just if this is something that you need to do, whether it's transiently or you're comfortable doing it long term, that's absolutely fine. But I think we just always need to remember the limitations of that. And you're right. I don't know how we can communicate all of these nuances to the layperson, to your average patient.
Yeah. Yeah. Well, I think that that's a great take-home message for patients, is just to understand that there are limitations, and having these conversations openly with your physician is important, so that we're not missing anything. But, some screening is better than no screening, right? So if this is the only
Yes.
screening that you can get done, yes, let's do it. But yes, there are some limitations there, which you've so well described. And the importance of, what we can actually see on the PAP, it makes me not want to give up the PAP in any way, shape, or form. I just think it's so invaluable. And I've been
you have a lot of good company. I think only about 1 to 1.5% of obstetricians and gynecologists in the United States use primary HPV testing regularly. 1%, and I think our doctors are voting with their practice. By that, it should sort of tell you something of how, despite what the data may say, that's how we feel about it, how comfortable we are with it.
I mean, I am always willing. I tell my patients all the time, I'm willing to change my mind when the data supports otherwise. But just because of my clinical experience of what I've seen, I just feel like it's too valuable to give up.
Yes. And, it is essentially almost collected in the same way. It's not like this is a urine test for HPV, which would of course be or salivary test for HPV, or,
Right.
it's still, it's still relatively invasive. So, and I get it. Being at home is, you're in privacy and you don't have to go to the doctors. It's easier. But if if you're gonna do that, why not go the whole way and get the very best test? Every woman deserves, I think, nothing less than the best test.
Yeah,
So.
agree. Well, thank you, Dr. Hopley, for your expertise and for your time today and for reinforcing patient empowerment and evidence-based care. I would love to include your recent article in our show notes for patients. If, some of us are visual learners, some of us are audible learners. And so having that written form may be helpful to kind of piece through this information.
I'd be delighted. Sure, please do.
Okay.
Thank you very much for having me. Appreciate you.
Thank you for joining us. Until next week, be well.